Okay, I'd like to welcome you back. It's been quite a fun lunch break. I hope some of you got an opportunity to do the stocking-a-thon. And we're changing focus this afternoon.
Your conference is now over.
We're getting
Goodbye.
more practical, and we hope to involve you, the audience, a lot more. So we're going to start off with a session on the new oral anticoagulants. On your program, it says it's myself and Dr. Matt Fay, but in fact, Dr. Matt Fay is perfectly capable of giving the whole of this lecture himself. He doesn't need me whatsoever. Matt is in the unique position that he's terribly young, but he's already had a Lifetime Achievement Award for his work as a GP in working with anticoagulation and changing practice. We're really delighted to have him today. Matt, over to you.
Thank you very much, Beverley. And it's a delight to be here and a privilege to listen to those patient journeys. Now, we've heard a lot of science this morning. I'm more of a kind of a pragmatic GP. So I'm going to amble through my view of all things anticoagulant. And I promised Beverley that I won't spend much time talking about AF, but I lied. So declarations, as usual. So I thought I'd take it through the challenge that we have. We heard a little bit of nice bashing this morning, so I thought, as somebody who sits on a couple of nice panels, I might try and rebalance the world a little bit for nice. Then we're going to look at NOACs and what we've been doing in Bradford, because we've been playing quite a lot in Bradford. We don't have many reasons to celebrate, but we have got a few. So the challenge is that the world has changed. And I'm with David in the fact that I quite like warfarin, but warfarin is not our only anticoagulant anymore. And I would argue with any health economy anywhere in this country that if it does not address the whole of anticoagulation, while it's trying to look at thrombosis prevention, while it's trying to look at stroke prevention in AF, they are doing it wrong, because we've now got a new world, and that world involves non-monitored and monitored oral anticoagulants. Now, what's quite nice about being in England is generally people like the healthcare system. Right up there at 92% of our population think that they're going to get good healthcare. Now, I'm listening to the patients this morning. I know that might not always seem true, but we have to try and maintain that standard. And to do that, that means we need to look at things that we're doing well, or things that have a lot of evidence to support their use, and do more of that, and look at things that we don't do well, or have very little evidence to support their use, and stop doing that. Anders talked a lot this morning about rationing, and I'm quite keen to ration stuff that doesn't work. What I'm not keen on doing is rationing stuff that does. So when I talk to my local public health consultant, a chap who many in this room may know, a guy called Greg Fell, about the fact that I found something new and shiny I would like to play with in the NHS, he says, absolutely fine, Matt, do whatever you want. What are you going to stop doing now? Because there's only so much money in the bucket, and we're going to have to stop doing stuff. So we do have a little bit of a one in, one out. And I don't think that the new anticoagulants are necessarily going to move warfarin out of the system, but there's other things we can attack, and if you put a little bit of brain power, you can get rid of them. Ezetimibe was a good one for us in Bradford. Our problem is that we have to deal with that rationing perspective in the full glare of the media. And no matter what intervention you're going to use, there will be a patient, there will be a consultant who believes it to be a good idea. And so we have to try and fight against that. And what we have to do that is NICE. Now, NICE has been around for a few years, and what NICE's job is to look at new things as they emerge, new evidence as it emerges, and try and come up with an idea that puts it into practice. So they've been busily working through their review program, their guideline group. Does anybody know what the first clinical guideline was from NICE? CG number 1? Schizophrenia. We're now up to 181, and half of them, I would say, have direct implications in general practice. Clinical guideline 3 was how to wash your hands. So, some of these are quite important, and NICE is churning these out with quite some aplomb. Now, the way that it does that is it asks for stakeholders to tell them what to look at. Quite often that might be driven by the pharma industry. If they've got a new drug or a new piece of research, they then go and ask the key clinical experts in the country if they think that's a good idea. So they get a bit of push and then they ask some experts. And then they go to the patients and say, well, everybody seems to be thinking this is what we should be doing. And they get patient involvement before they start thinking about putting together a guideline development group. Myself and David have been sat on the AF guideline group just recently to try and develop a guideline around how we should manage a condition. Now, quite often, when it's not our area of interest, sometimes the evidence can feel a little bit like this that NICE is looking at. But having now actually gone through the process, it's very exacting how they look at the evidence and try and produce a guideline which is supported by that evidence. They're taking on a lot of things. So not only are they developing the guidelines, they're also developing some of the levers to assist with those guidelines. So if we look that they are now in control of the QOF, the Quality and Outcome Framework for General Practice, which gives them a contractual lever against or in support of GPs to try and ensure that they do good clinical practice. So NICE is very involved, and I would suggest to you, any of you who wants to try and influence the system as it stands at the moment, NICE is a good door to knock at because it is a way in. And the way that they do this is they pick up a topic, they look at the evidence, they develop a guideline, they then develop the next step, which was alluded to by one of the earlier speakers, around the fact that they put together a quality statement. They try and pull out the key points of any guideline and sit them in a series of statements that places can be judged against and benchmarked. And then they get the quality measures, which again, as we've heard, are part of our payment strategy in the fact you can give people targets. So that's what NICE is doing. Now, NICE is very active in this area because it's just done the AF guideline, and that was published in June. And a couple of years ago, it did the treatment of venous thromboembolism. So NICE is very active here. We have guidelines that we can look at and try and reflect practice. We also have technical appraisal documents for many of the new agents. Now, for those of you who don't know what a technical appraisal is, it's where NICE does the cost analysis and tries to work out whether these drugs are cost effective. And for AF, all the licensed drugs have undergone a technical appraisal and have a positive technical appraisal. And we also have a positive technical appraisal for Rivaroxaban in VTE. Now, the interesting thing about technical appraisal means that the CCGs, the clinical commissioning groups, are statutorily obliged to fund these drugs. It is no longer choice. They have to find the money to support their implementation. So, although Anders said it was NICE, NICE hasn't quite been the barrier here. What's the barrier here is what's going on in those local areas. So some areas are different from others, and I'll show you that later. One thing that's true is despite positive technical appraisal, in England, the use of the NOACs is still sat about 3%, which seems dreadfully poor when you consider that just in AF as an area, we're seeing about 7,000 to 10,000 strokes a year that could have been prevented by the use of an oral anticoagulant. So this is having consequence, and it's having consequence because of rationing, because these drugs are all approved. You have the right to go to any doctor in the NHS and say, I want this drug, because they are approved and they should be funded. So I was sat on a train a few years ago coming down to this beautiful city. I spend a lot more time here than I do in practice sometimes. I was reading my way through a study called Einstein. Now, the reason I was reading it is because I'm like David, I like warfarin, and these new drugs were interloping into my area. Now, the day before, I'd had a dreadful experience as a clinician. The patient had an even worse experience. But I had a dreadful experience as a clinician trying to get somebody assessed for a possible DVT. The pathway was absolutely incomprehensible. And I sat down and I read Einstein on the way down, and I thought, this is a nice piece of work, this drug's all right. But hidden inside those pages was actually a much better way of managing DVT. And so on the way back up, I drew out my first scribble of what I thought the pathway for DVT should be. And I started to sell it to my friends in Bradford. So I'm just going to take you a little bit through my journey as we change things in the Bradford area. So Einstein comes out in 2010. Before that, in Bradford, we had a nurse-led service using plasmography, where they grab hold of your calf to see if there's any blood flow. And we were using low molecular weight heparins and then subsequently warfarin. Most patients, because the community pathway had become so poor, were actually being admitted to hospital. In this day and age where we've got to, I can't believe that that was true. So we did have this advantage in Bradford that we had a dreadful DVT pathway. Then we get Einstein published, and that's where I started. We also get a little bit of inside information about what the clinical guideline was going to look at, and we had Bayer telling us that they were almost certainly going to get a good technical appraisal. So the dominoes were starting to stack up on the fact that we could do something interesting. And so we started to look at a completely community-based DVT pathway, where I would see a patient and I would initiate therapy and just arrange ultrasound scanning to exclude thrombosis at the hospital. We got a couple of the CCGs on board, so Bradford District and Bradford City. The radiologists were ecstatic. One thing you find out about radiologists is they're paid irrespective of where the patient came from, so they didn't care unless you were going to get more work, which they liked even more. We had a haematologist who thought it was a good idea. I think he doesn't like his warfarin clinic very much, and he saw this as a really good way to decrease the volume going through his warfarin clinic. And everything seemed to be stacking up in the right direction. We had strong clinical engagement saying that this was a good idea. Then what happened was that one of the prescribing directors in the local hospital realised that this was going to defund the warfarin clinic. We were going to take money out of the system somewhere. And so he essentially put the brakes on, because as with everything in the NHS, you've got to deal with the bureaucracy. I've now resigned from CCG, so this actually is vacant for me. And we have to work it forward. So what did we do? We got an excellent lady by the name of Claire Smart, she definitely lives up to her name, who came in as a commissioner. And when we're all sat around the table, all the clinicians going, yeah, the money's a problem, yeah, no, we understand that. She just sat there and said, right, this is a better pathway. All the doctors say it's a better pathway. You either do it this way or we'll find somebody else to do the scans. And I really wished it had been completely clinically driven, but ultimately it came down to a contractor throwing down the gauntlet, at which point the hospital decided it would actually capitulate and give us the pathway. And that's the pathway. So this is the entire pathway for DVT in Bradford on one side of A4. It's also the referral form. So whenever the GP wonders what they should do, it's all there on the referral form. We have simple exclusion criteria because, of course, Rivaroxaban, which is the drug we're using, is not licensed for all. We've now removed the symptoms of PE because Rivaroxaban is now the drug of choice in the Bradford hospitals for treatment of PE. We also put the Wells score there so that the GP didn't have to look anywhere else. The computer system actually will generate it for you anyway, so the GPs don't even have to think about it, they just have to click radio buttons. And we've also made it so that they can get easy access to the D-dimers. So everything the GP needs is there. They do their bit, so they assess somebody to see if they think it's a thrombosis. They think it's a thrombosis, they give them a prescription for the first 21 days of Rivaroxaban, and they fax this form over to the hospital where it's picked up by the radiologists. Now, in doing this, we were very, very conscious that this was a drug that scared people. Our medical advisors had been going out for a while saying, beware that MAC-Fay and those new drugs, because we can't stop people bleeding on these, you know. So they were all terrified in the local community that they were going to start drugs that we couldn't stop. So Sam got together with the emergency clinicians in our hospital as a haematologist, and they drew up a very, very clear plan of what would happen if somebody presented into the hospital bleeding on Rivaroxaban. It's been tested. Unfortunately, we did have somebody who had a significant bleed on Rivaroxaban. To be fair, it did break David Fitzmaurice's first rule, which is if you are already actively bleeding, please don't actually start an anticoagulant because it's not going to go down well. And the patient was almost certainly bleeding from a large duodenal ulcer, causing anemia-induced heart failure and the edema that the GP misdiagnosed as a DVT. So we got that in place to reassure the doctors that this is not as dangerous as you might think. The next part of the algorithm is on the chart that the GPs send off, but this is all within the radiology department. So they go to the vascular radiology department, they have an upper leg scan. If that's negative, they have a standard the ultrasonographers have a standard letter they give to the patient to tell them to discontinue their anticoagulant for a week, and they rebook the scan. So I'm not involved. The radiology department sorts out all the subsequent follow-up for second scans. And if it's positive, the positive scan becomes the referral to the thrombosis clinic. All I get for the negatives is a call to say, can you make sure this patient stops their Rivaroxaban? And that's it. We didn't pay the GPs to do this. As far as I was concerned, the assessment of a DVT using the Wells score and D-dimer was core general practice. What did we give them? We gave them a pathway which was simple, and we've actually currently audited it, and we've got 94% adherence to pathway. So the majority of patients from the City of Bradford are being managed in an evidence-based, NICE-approved manner with a NICE-approved medication, and patients are flowing through the system without problem. What do we do in the thrombosis clinic? We give them a quality of care that they didn't have before. Because actually what happened with the patients before was they were sent into the Warfarin clinic and they had their 3 or 6 months of Warfarin as determined at presentation, and it was just discontinued. There was no formal thrombosis follow-up in Bradford. So these are now all being seen in a specialist clinic, overseen by somebody who knows what they're talking about. What's even nicer is we persuaded the hospital on this occasion to come inside the GP clinical system of System 1 so that actually we can see all the activity that's going on in the thrombosis clinic as well. It's all documented directly into the single patient record. So that's worked very well for us. But this leads to another problem, and it's, is there a problem with the NOACs? Now, there is a problem with the NOACs because across this country only 3% of people are actually receiving a strongly evidence-based safe drug. So there must be something wrong. Firstly, I think we've got to get their name right. So we started off with new, and they can't be new because they've been out for a year, so that means it could be novel, but they're not particularly novel. Heparins have done this for years. We've got direct. I really like the TOSAT. I've got a feeling that might be put together by somebody with an interest in Warfarin. And Oddies is another one, you see. But I think that, NOACs is a term we all know, and we just need to bend this abbreviation in whatever way we want to keep NOAC in place. We have some nice big studies, particularly in my area of interest in AF, comparing the drugs at different doses. We can see benefit across the system, but how do they compare together? Well, we haven't got a single comparison, but we can look at some data. So we've got a meta-analysis, which actually shows that for prevention of stroke and systemic emboli, these drugs are better than Warfarin. And Warfarin was a hell of a high mark, and we've managed to get something better. In some of them, they look like they're safer in the bleeding as well. And this is a big cohort of patients. What about the full dose? As Anders was saying this morning, we've got these drugs which their safety profile seems to really drive us down a line of saying, why aren't we using these, particularly in a condition like AF, when our big concern is stroke? And I would suggest to anybody that when a patient suffers a stroke, whether that be cardioembolic due to their AF or hemorrhagic due to the treatment that they're on for their AF, it's still a stroke. And we have drugs which are safer for patients as regards that cataclysmic complication. What about bleeding with Dabigatran? You know, the bad reputation stuff is really hard, and maybe we do get a bit more GI bleeding with Dabigatran against reduced intracerebral hemorrhage. So I think we have to be careful how we look at that. When we look at how safe it is, because we all know it's been in the news, well, the data is there comparing it with warfarin, and the only place that it really loses against warfarin in its own studies is against GI hemorrhage. In all other respects, it seems safer. Even the concern that we had about a myocardial infarction that we got from Rely, we see it to be safer. But we still can't stop even the British Medical Journal doing somewhat sensational headlines to try and undermine these medications. And we have to try and pull away from this, because ultimately they are comparing to a drug with an incredibly high standard of care, and these drugs are better. What about this reversibility? Because we can reverse warfarin. We're always told that. We can't reverse these new drugs. Well, we can give people vitamin K, but only if you've got time to wait around a little bit. And when we compare that to the NOACs, actually by the time the vitamin K kicks in, the NOAC would have stopped working anyway, so just don't give them another dose. And I think we're scaring people away from drugs with a fantastic health opportunity just because there's a little bit of us getting a bit paranoid. What about PCC with Rivaroxaban? We can see in experimental models we can reverse this drug. And what we need to see is it in clinical practice. And most people, when you look at their guidelines in clinical practice, they are suggesting that we use PCC. So we are able to affect bleeding in these drugs. And we've got the new agents, the new reversal agents are just around the corner. It's going to be interesting how they get FDA approval, but they are just around the corner. So we know that we're going to be able to reverse these soon, and we need to be cautious of our anti-advice about the use of these drugs. Monitoring, they do all kinds of things. So we need to stop wasting money on blood tests to monitor drugs. Well, actually, we don't need to actually monitor these drugs very often. And when we do, if you really bend the ear of your local haematologist, you probably can do a 10A, active 10A level. So you can monitor it if you really want to. But do you really want to when the evidence suggests that we don't need to? So just about the NOACs, these are at least as safe as warfarin. Their intracerebral bleed rates are lower than warfarin. They shouldn't be used for valvular AF, but non-valvular AF, the vast majority of that marketplace, this is a useful intervention. Maybe you get a bit more GI bleeding, but as long as the patient is aware, then we should be able to deal with that. You probably can test for them if you wanted to. I think the reversibility thing is being massively overhyped. And let's face it, the real driver here against the NOACs is the problem with their cost. But I've yet to find a patient who can put the value on their loss of ability due to a stroke in AF. Just to also have another slight dig at Anders, the NICE guideline in AF is very, very clear that actually the only reason that a patient should go onto a vitamin K antagonist is because they chose to do so. So it's actually very clear in our guideline in AF that this is now the position. So we had I know of several CCGs around this country that were saying we don't know where they fit in the pathway of care. That's where they fit, and that's the national guideline. So when do you have the choice to have a novel oral anticoagulant? When you ask for it. But when we look, and this is some data I've stolen from Derek Todder, who's a cardiologist in Liverpool, who's a bit disappointed with the uptake of the NOACs in his city, what we see is we're seeing similar kind of levels to what we're seeing nationally. So is this a national problem? Well, when we look here in London and in Dudley, in Birmingham, no, we're not seeing that. What about Bradford? No, we're not seeing that. So this is local health politics running amok and denying people access to NICE approved drugs that they are supposed to finance through local health politics, and almost certainly to the patient's detriment. So how are we going to move forward? The only way we're going to move forward is to keep on pushing at that particular door. So the challenge is that we've changed the world of anticoagulation. The work that's come out of our academic centres has shown us a new way to manage people with thrombotic conditions. NICE is there, and actually for most of these agents, NICE is a big supporter of their use. They say they're cost effective. I would suggest to any of you that a NICE quality standard for AF will be coming out for consultation in January. Put yourself in as a stakeholder, because there's almost certainly going to be mention of the anticoagulants in there. DVT in Bradford, we changed the whole pathway. We gave the GPs the confidence to use the new anticoagulants in a common situation for them, the possibility of DVT. And what we've seen is it's enhanced their confidence to use them in the long-term situation of AF and stroke prevention. And the NOACs aren't quite the devils they've been made out to be. If we look at them in a real situation, we find that actually they're as safe as warfarin, if not safer. And in certain situations, I think they have to be the drug of choice. Thank you very much.
Fabulous. And just to say before we take questions that Lifeblood now have a statement on their website saying that if you have a condition where NICE have approved a NOAC can be used and you're having difficulty in accessing it, can you please contact us, because we want to do some media work around this later in the year. So Matt, I think you've said everything. Does anyone have any questions about NOACs? You're all very clear. Ander.
The only man I wanted not to.
I'm the last person to worry about something having to go at something.
Yeah.
That's fine, lifestyle. I want to ask you, when I read the NICE guidelines, they say these should be used for patients that where there is difficulty in managing the INR. That's what it said in the past.
Yeah.
Agree?
No.
No. And no, there's actually...
The technical appraisals all follow the study. I mean, if the patient has a CHAD score of 1, they are eligible for these drugs.
And there's actually a NICE NIC. Do you know about the NIC?
Yeah, I'm involved.
So NICE collaborative.
I've read the Gloucestershire stuff,
Yeah.
nice. I've read the Wales look nice. I've read this look nice.
Yeah.
They all say use this in patients only.
No.
No, so the NICE NIC...
It's not that. What we put into the new NICE guideline is to say that in those patients who have chosen warfarin, so their first drug, and I do have a few patients who still say, I want the old-fashioned staid, and I come from Yorkshire, we like it up there. And they still want that. But if their control goes off, then I sit them down and have a conversation with them. So you were commenting on TTRs in clinic. I've got a moderately sized anticoagulation service I've been running for years. Why I like warfarin, sorry, I'm so conflicted. And the TTR in my clinic's 88%. Why? Because I've been pulling out the poor controls for years and putting them on NOACs.
Yeah, I think I have different from TTR. But my point is this. I mean, you showed me 2 slides with 7 bullet points on what you went through to get a paper that I co-wrote, the Einstein paper, through.
Yeah.
You showed me the sort of trouble you'd have to get AF.
Yeah.
Something's wrong.
Without question.
So
And
I mean, this fundamentally, for what I would describe as being obvious, we're having to go through this rigmarole.
Anders, I have absolute agreement with you. I don't believe there are still areas of this country that are putting people into hospital to inject them with low molecular weight heparins when you can do it all in the community. There is absolutely no reason for them to be there. And in the Bradford model, we've saved for our health community about 400,000. So this is not an expensive pathway. This is a cost-effective pathway that puts patients centre. I've not put on the slides, and if I'd realised with so many patients coming, I would have. We did a patient satisfaction survey on what they thought of the pathway. And what was interesting was the people where it was their first thrombosis, they were complaining about parking at the hospital, and they were complaining that they didn't get quite the appointment that they wanted to fit in with their busy lives. The people who had been through our previous pathway were just absolutely astounded that we could have taken something so poorly controlled around the patient. Well, it wasn't. It was centred around the healthcare community, not the patient. And we can build something which was so patient-friendly on the other side of it. And so I can't accept anybody saying that we should stick with the old pathway. Just can't accept it. And thank you for the paper. It helped.
Thank you. I'm very sorry we have to move on, but please grab Matt and talk to him later on. Thank you very much. It's brilliant.